you take it every morning. Maybe with your coffee, maybe before you have even opened your eyes all the way. A small pill, a sip of water, and you move on with your day feeling like you have done the responsible thing. And here is what nobody has told you. That small act of responsibility might be the exact place where the biggest mistakes happen. Not because the medication does not work, it works extremely well, but because almost nobody explains what it is actually doing inside you or what it needs from you in return, week after week, year after year. If you take Amlodipine, Losartan, or Lisinopril, I am about to walk you through 9 things about your own medication that almost never get explained in a 15-minute appointment. Some of them will surprise you. One of them could genuinely change how safe you are, and it has nothing to do with whether you remember to take your pill on time. Stay with me through all 9, because the ones near the end matter the most, and the very last one is the belief I hear more often than almost anything else in my own office. Before we get into it, if you are the kind of person who wants to actually understand your own health instead of just following instructions blindly, this channel is built for you. Joining our community here means every future video like this one reaches you first, and it helps me know exactly which topics matter most to people your age. So consider becoming part of that community today. It genuinely helps shape what I make next, and it costs you nothing but a single tap. By the way, in case this is your first time here, my name is Dr. Matthew Clark. I am an internal medicine and preventive health doctor, and for the past 15 years, I have worked specifically with men and women over 50 who are trying to stay ahead of their health instead of reacting to it after something goes wrong. Blood pressure medication happens to be one of the areas I see the most confusion in because it works quietly in the background. It does not hurt. It does not announce itself. There is no ache, no warning sign, nothing that taps you on the shoulder to say, "Pay attention here." And that silence is exactly why so many small mistakes slip through unnoticed for years, sometimes for decades, without a single person ever raising a flag. Compare that to something like a broken bone or a bad tooth, where your body forces you to deal with it immediately because the pain simply will not let you ignore it. Blood pressure medication does not work that way, and neither does the condition it is treating. That mismatch, a serious problem with no built-in alarm system, is exactly why understanding your medication yourself becomes so important. Nobody else is going to feel it for you, and nothing inside your body is going to insist that you pay attention. Here's a question before we go further. Have you ever looked at your own pill bottle and genuinely wondered why your doctor picked that specific medication for you instead of one of the other 2? If you have never really known the answer, you are not alone. And by the end of this video, you will, along with a short list of exactly what to ask at your next appointment. Here is the first thing almost nobody explains clearly, and it is the foundation for everything else in this video. Amlodipine, Losartan, and Lisinopril are not 3 versions of the same drug. They are 3 completely different tools that happen to arrive at the same destination through entirely different roads. And understanding which road your medication takes changes how you should think about every symptom that follows. Amlodipine belongs to a family called calcium channel blockers. Picture the muscle wall around your blood vessels like a fist that is gripping just slightly tighter than it should, hour after hour, day after day. Amlodipine gently loosens that grip, allowing the vessel to open wider so blood moves through with less resistance and less strain on your heart. Losartan works completely differently. It belongs to a family called angiotensin receptor blockers. There is a hormone in your body called angiotensin that, when it locks onto certain receptors, tells your blood vessels to tighten and your body to hold on to extra fluid, raising the pressure inside your entire system. Losartan sits on that receptor like an occupied parking spot, blocking the hormone from ever docking there in the first place, so the tightening signal simply never arrives. Lisinopril takes yet another road. It belongs to a family called ACE inhibitors, which stands for angiotensin converting enzyme. Instead of blocking the parking spot, lisinopril stops the hormone from ever being fully created in the first place, cutting the problem off one step earlier in the chain, before the tightening signal even has a chance to form. 3 different mechanisms, one shared goal, which is exactly why the specific one you were prescribed was not a coin flip. It was chosen based on your particular kidneys, your particular heart, your particular age, and your particular risk profile. That is the first thing. Number 2 is where it gets personal for a lot of you watching, because there is a very good chance you have already lived through this one without knowing why it was happening. Number 2, if you take amlodipine and you have noticed your ankles or your lower legs swelling by the end of the day, I want you to hear something important. That is not automatically an allergic reaction, and it does not automatically mean the medication is failing you or harming you. Remember that amlodipine relaxes the muscle wall around your blood vessels. In the small vessels of your legs and ankles, farthest from your heart and most affected by gravity, that relaxation can be more pronounced than in the larger vessels closer to your chest, and a small amount of fluid can shift into the surrounding tissue as a result. It is a known, well-documented effect of this specific class of medication, seen in a meaningful percentage of patients who take it, not a sign that something has gone catastrophically wrong inside you. What it does mean is that this is worth a real conversation with your doctor, because sometimes a small dose adjustment, a change in the time of day you take it, elevating your legs in the evening, or a switch to a related medication solves it completely within a week or two. What it does not mean is that you should quietly stop taking it on your own because your ankles look puffy by dinner time, since stopping abruptly carries its own risks that we will get to shortly. Number 3, and this one explains a mystery a lot of you have lived through without ever connecting the dots. If you were once on Lisinopril and developed a persistent dry cough that would not go away no matter what you tried, cough drops, allergy medication, humidifiers, and your doctor eventually switched you to Losartan, that switch was not random, and it was not because Lisinopril had failed you. Remember that Lisinopril blocks an enzyme called angiotensin-converting enzyme. That same enzyme happens to also break down a separate substance in your lungs called bradykinin. When the enzyme is blocked, bradykinin can build up in the airway tissue, and in a meaningful percentage of patients, somewhere around 1 in 10 by most clinical estimates, that buildup irritates the airway enough to cause a persistent, dry, tickling cough that lingers for weeks. Losartan, because it works through a completely different mechanism further down the same pathway, almost never causes this same cough, which is exactly why that switch happens so often in practices like mine, and why understanding the mechanism from number 1 suddenly makes this entire pattern make sense instead of feeling like a mysterious coincidence. Now I want you to actually do something with me for a moment. Take 2 fingers and find the pulse at your wrist right now. Feel that steady rhythm underneath your skin. Every one of the 3 medications we are discussing today is, in some way, working to protect that exact rhythm and the vessels it travels through every single hour of your life, whether you feel it happening or not, whether you are asleep or wide awake. Number 4, and this is one of the more overlooked ones in my experience. Both Losartan and Lisinopril can raise the potassium level in your blood, because part of how they work involves a hormone system that also regulates how your kidneys handle potassium. Potassium is a mineral your heart depends on for a steady electrical rhythm, but too much of it can actually cause dangerous heart rhythm problems of its own, including rhythms that can become life-threatening if left unchecked. This becomes especially important if you use a salt substitute at home, because many of those substitutes replace sodium with potassium chloride specifically to help people cut back on salt, and combining that with one of these medications can push your levels higher than your doctor expects without either of you realizing it until a routine blood test catches it. This is the first thread I want you to hold on to for a moment, because I am going to come back to it later in this video with something most people never think to ask their pharmacist about directly, and it ties directly into a second issue that most patients never connect to this one. Let me tell you about a pattern I have seen more times than I can count in my own practice. A patient comes in feeling completely fine, blood pressure numbers looking good on paper, energy normal, no complaints at all, and they assume that means everything underneath is running smoothly too. What they do not realize is that a stable number on a home monitor does not tell you anything about your kidney function or your potassium level. since those require an actual blood draw to measure, which is exactly why routine blood work matters even when you feel perfectly well and have absolutely no reason to suspect a problem. Number 5 is a smaller detail, but it surprises a lot of people the first time they hear it because it involves something as ordinary as breakfast. If you take amlodipine, grapefruit and grapefruit juice can interfere with how your liver processes the medication, specifically by blocking an enzyme responsible for breaking it down, allowing more of the drug to build up in your bloodstream than intended and potentially amplifying its effects. This does not mean you can never enjoy grapefruit again for the rest of your life. It means this is worth a direct question to your doctor or pharmacist, because the degree of interaction can vary meaningfully from person to person depending on dose and individual metabolism. And getting a clear answer takes 30 seconds of conversation and removes the guesswork completely instead of leaving you wondering every time you reach for the fruit bowl. Numbers 6 through 9 are the ones I most want you to remember because these are the ones with the highest stakes attached to them, and these are the 4 that, in my experience, actually change outcomes. Number 6. Never, under any circumstance, stop Losartan or Lisinopril abruptly on your own, even if you feel completely fine and even if your numbers have looked perfect for months. Both of these medications are involved in a hormone system that helps keep your blood pressure regulated around the clock, continuously in the background, without you ever noticing it working. When you stop suddenly, that system can overcorrect, and in some patients, this produces a rebound spike in blood pressure that is higher than their baseline before they ever started the medication in the first place. That rebound can happen within days of stopping, sometimes even sooner, and a sudden spike in blood pressure meaningfully raises the short-term risk of stroke and cardiac events during exactly that window. If a medication ever needs to change, for any reason, the safe path is always a conversation with your doctor about tapering slowly or switching carefully, never a quiet decision made alone at home based on how you happen to feel that week. Number 7 touches on something that gets debated constantly, even among physicians who specialize in this exact area. There has been real discussion in recent years about whether taking blood pressure medication in the morning or at night produces better protection overall, particularly because blood pressure naturally follows a rhythm throughout the day and tends to dip during sleep in healthy patients, roughly 10 to 20% below daytime levels. In some patients, that nighttime dip does not happen the way it should, a pattern sometimes called non-dipping, and taking a dose in the evening may offer better overnight protection for those specific patients. This is not a one-size-fits-all answer, which is exactly why the right move is asking your own doctor whether your specific pattern, based on your own monitoring, would benefit from a timing change rather than switching the time you take your pill based on something you happen to see online or hear from a neighbor. Number 8 brings us back to the thread I promised I would return to. Both Losartan and Lisinopril require your kidneys to be functioning well enough to handle the shift in blood flow they create, since the same hormone pathway they interrupt also plays a role in regulating pressure inside the kidney itself. In a small number of patients, kidney function can be affected by these medications, particularly when combined with certain other drugs like common over-the-counter pain relievers, such as ibuprofen, which can compound the effect on kidney blood flow. Here is the question almost nobody thinks to ask directly, and I want you to actually write this one down. At your next appointment or your next pharmacy visit, ask specifically when your creatinine and potassium were last checked together, and how often your doctor recommends rechecking them while you remain on this medication. That single question closes the loop on both threads I opened earlier in this video, the potassium risk from number 4 and the kidney question right here, and it takes less than a minute to ask, yet it can catch a problem months before it would otherwise surface. Number 9 is the belief I most want to dismantle today, because I hear a version of it from patients constantly, almost weekly, regardless of how many times I explain it during an appointment. Many people assume that once their blood pressure numbers look good on the home monitor for a few months in a row, the underlying problem must be fixed, resolved, cured, and the medication can quietly be tapered off or stopped without telling anyone. That is the myth. Here is the reality. In the overwhelming majority of cases, those good numbers are not proof that the underlying condition disappeared. They are proof that the medication is doing exactly what it was designed to do, holding the pressure steady while it works quietly in the background, day after day, without applause and without complaint. Blood pressure has no symptoms of its own most of the time, which is precisely why it earned the nickname the silent condition decades ago among physicians. Feeling fine has never been a reliable measurement of what is actually happening inside your arteries, and it never will be, no matter how good you feel on any given morning. I think about a woman I saw regularly in my practice, a retired schoolteacher from a small town outside Columbus, who had spent 30 years teaching second grade before retiring. She had been on Lisinopril for almost 3 years, and her readings had looked excellent for most of that time, consistently within a healthy range at every single visit. She assumed, reasonably from her own perspective, that her blood pressure had simply resolved itself the way a cold eventually clears on its own, and she quietly stopped refilling her prescription one winter without mentioning it to anyone, not her family, not her pharmacist, not me. 6 weeks later, at a completely unrelated appointment for a minor foot issue, her blood pressure reading came back significantly elevated, high enough that we needed to restart treatment immediately and monitor her closely for several weeks afterward to make sure nothing more serious had already begun. Nothing about how she felt day to day had changed during those 6 weeks. She had no headaches, no dizziness, no warning of any kind. That is the entire point of this story. The absence of symptoms was never proof that everything underneath was fine, and it very nearly cost her far more than an uncomfortable follow-up visit. I have seen a version of this same pattern play out with men just as often as women, sometimes with a slightly different shape. A retired mechanic I treated for several years, a man who had spent his whole career trusting his own hands and his own judgment over almost anything else, told me flatly one afternoon that he had cut his Losartan dose in half on his own because he felt his energy had been a little low that month, and he assumed the medication was the cause. He had not mentioned it to me, and he had not had his levels checked since making that change. It took another 8 weeks before his numbers had drifted high enough for us to catch it at a routine visit, and in that window he had no idea anything was different because nothing felt different to him at all. This is exactly the kind of pattern that plays out quietly in homes across this country every single week, often without anyone realizing it until much later, and it is exactly the reason a channel like this one matters to me personally. The healthcare system, as it currently exists, is genuinely excellent at treating a crisis once it has already happened, with remarkable speed and skill. It is far less equipped to sit with you for the 10 extra minutes it would take to explain what your medication is actually doing and why stopping it quietly is dangerous. There is no billing code for that 10-minute conversation, no line item that pays a clinic for prevention explained well, so it rarely happens the way it should, and patients are left filling in the gaps with assumptions instead of facts. This is exactly why I make videos like this one, and exactly why your support of this channel matters more than you might think. If even one person watching right now avoids a rebound blood pressure spike because of something explained here today, this entire video will have done its job completely. If that resonates with you, consider sharing it with someone you know who takes one of these 3 medications, a parent, a spouse, a neighbor, because there is a real chance this reaches them before a mistake does. And if you are not already part of this community, joining today helps this message reach more people just like you, quietly, one person at a time. Before we move into the closing steps, I would love to know one thing about you. How old are you right now? I ask because it genuinely shapes what I recommend, since the considerations for someone in their 50s can look meaningfully different from someone in their 70s or 80s. And it also shapes exactly which topics I choose to cover next on this channel. Drop your age in the comments below, and I promise I actually read them. Here is something that might genuinely surprise you. The 3 medications we have discussed today are so commonly prescribed that on any given morning across this country, tens of millions of people are taking one of them at almost the exact same moment you are, in kitchens and bathrooms and bedside tables from coast to coast. and yet the majority of them could not tell you which class their medication belongs to, or which of the 9 things we just covered applies specifically to them. Understanding your own medication is not a small thing. It is one of the most protective habits available to you, and unlike most things in healthcare today, it costs absolutely nothing. Earlier in this video, I told you I would come back to something. That question about when your potassium and kidney function were last checked together is not a small detail buried in the middle of a list. For many of you watching, it may be the single most useful thing you take away from today, because it is the one gap in routine care that quietly slips through the most often, even among patients who otherwise manage their health carefully. Ask it at your very next appointment, and if the answer is longer ago than a year, ask to have it rechecked soon. And one more thing before we get to your action plan, I would genuinely love to hear from you in the comments. Has anything in this video matched your own experience with one of these medications? Whether it was the swelling, the cough, the timing question, or something else entirely that we have not even touched on today. And if there is a topic related to your heart, your blood pressure, or aging well that you would like me to cover next, tell me there too. This channel exists because of exactly that kind of feedback, and more of these videos come directly from comments just like the ones you leave. One more honest moment before we close, and I think it is the most important thing I will say today. If you follow the guidance in this video closely, work with your doctor on timing, get your blood work checked regularly, and your numbers stabilize beautifully for months at a time, there will very likely come a day where you feel completely normal, energetic, symptom-free, and you start to wonder whether you still need any of this at all. That exact moment, the moment you feel best, is not the finish line. It is the real test of whether you understood everything we just covered, because that is precisely the moment the myth from number 9 tries to talk you into stopping, dressed up as common sense instead of the risk it actually is. So let me give you a clear, doable action plan to walk away with today, one you can start on before the day is even over. Number 1. Identify exactly which of the 3 medications you personally take, and understand which mechanism from the beginning of this video applies to you specifically, so every symptom you notice from here forward makes sense in context instead of feeling random. Number 2. If you take amlodipine and notice ankle or leg swelling, do not stop the medication on your own. Bring it up at your very next appointment and ask about dose timing, leg elevation in the evening, or adjustment options that can resolve it without abandoning a medication that is otherwise working well for you. Number 3. If you have ever had a persistent dry cough on lisinopril, ask your doctor directly whether losartan might be a better fit for your specific situation, since the mechanism behind that cough almost never carries over to the other medication. Number 4. Ask your pharmacist or doctor when your potassium and kidney function were last checked together, and how often that should be repeated while you remain on this medication, and write the answer down somewhere you will actually see it again. Number 5. If you use a salt substitute at home, check the label for potassium chloride and mention it at your next appointment, especially if you take losartan or lisinopril, since the combination is easy to overlook from both sides of the conversation. Number 6. Never stop any of these 3 medications abruptly without medical guidance, even if your numbers have looked excellent for months, even if you feel completely fine, even if a friend told you it should be fine. Number 7. Ask your doctor whether a morning or evening dosing schedule makes more sense for your individual pattern, rather than assuming one timing fits everyone, especially if you already track your own readings at home. The 8th step, and this one applies specifically if you are ever considering adding any new supplement, herb, or over-the-counter pain reliever alongside these medications. Talk to your doctor before starting anything new, since certain combinations can affect both your kidney function and your potassium level in ways that are easy to miss until a routine test catches them, sometimes months after the fact. And thank you genuinely for spending this time with me today. If this video gave you even one piece of information you did not have 20 minutes ago, consider joining our growing community here so future videos like this one reach you first. This channel is built entirely around helping people just like you stay ahead of their health instead of reacting to it after the fact, and every single person who joins helps that mission grow just a little further, one viewer at a time. I know there is a lot of health content out there competing for your attention, and I do not take it lightly that you chose to spend this particular 20-something minutes with me. My goal has never been to frighten you about medication you are almost certainly already taking safely. My goal is simply to make sure the pill in your hand each morning is something you actually understand, not just something you trust blindly because a doctor once wrote it on a slip of paper. That understanding is yours to keep, regardless of what happens with this channel going forward, and I hope it serves you well for a long time. And one last important note before you go. Everything in this video is intended for general education, drawn from real clinical patterns I see regularly in my own practice, and it is not a replacement for the personal guidance of your own physician, who knows your full medical history, your full lab results, and your full story in a way no video ever could. If anything discussed today applies to you, please bring it up at your next appointment rather than waiting for it to resolve on its own or hoping it quietly sorts itself out. Take care of yourself. Take care of that pill bottle sitting on your counter, and I will see you in the next one.